It's okay for you?
Yeah.
Okay.
You can start if you want.
There is two big chapters, the spontaneous coronary artery dissection and the catheter-induced coronary artery dissection. I will start with the spontaneous coronary artery dissection. And I will show you two cases. The first one, it's a long QT and Brugada syndrome in a 24-year-old woman who had a pulsus electrical activity cardiac arrest after cesarean delivery. Troponin levels were significantly elevated and EKG revealed Q waves with loss of voltage in lateral leads. So as we can see here, the cardiac cath images shows smooth stenosis of the left main extending to the proximal LAD, resulting in about 70% stenosis from intramural hematoma. Picture B and D, this is a scanner that shows a dissection of flap in the left main, as we can see in the here, and resulting in
this is well evidenced the flap. It's quite clear at the CT scan. So for those that are less experienced on the CT scan and the coronary dissection, this is a very nice picture of this type of disease. Can you see it? Can you understand it?
So
all right.
The red arrow, this is the dissection, and the black arrow, this is the intramural hematoma and the proximal LAD.
Yeah, nice.
Okay, so 2 years after, the patient presented with a right-sided headache. So they do an angiography of the internal carotid artery that shows here also a dissection in the right internal carotid artery. As we can see in the picture E, here it's a dissection also in the right carotid artery. So it's a very important topic about correlation between coronary CT angio features of spontaneous coronary artery dissection with invasive coronary angiography. Here we can see the three types of dissection, spontaneous coronary artery dissection. The type number 1, as we can see in the coronary angiography, multiple lumens and contrast material staining with complete occlusion distally. And here we can see it in the coronary CT angio. Type 2, diffuse smooth stenosis. Usually it's a long stenosis more than 20 millimeter. And also we can see it here in the reconstruction of the coronary CT angiography. And the type 3 of spontaneous coronary artery dissection, it's a focal, usually a short segment stenosis, usually about less than 20 millimeter.
So Rima, briefly, just again to punctualize what you have correctly said.
Yes.
Spontaneous coronary artery dissection is a disease that typically occurs in young women, not only in young women, of course, but there is a good prevalence in women of around 40 to 50 year old, and is correlated to the rupture of the intima of a coronary artery with the formation of a hematoma inside of the artery, which can cause, which can be benign and asymptomatic, or can cause the obstruction till the total occlusion of the vessel, so leading to either myocardial infarction or stroke, like in this case.
Yeah. I will discuss it later on after the cases.
Oh, sorry.
I started with the,
sorry.
Thank you so much. Yeah. So the case number 2, a 34-year-old man with a history of diabetes mellitus who presented with acute chest pain. And they did aortic CT that did not depict acute aortic dissection or acute intramural hematoma. So they do cardiac cath images, and figure now A shows cardiac cath images along the stenosis 90% of the proximal LAD and the ostial first diagonal branch, secondary to probably underlying intramural hematoma that can be shown here in the IVUS images. If you can comment, please, doctor.
Yeah, here, you know, one of the problems with a SCAD is that contrast dye, especially if given and administered at high pressure, can cause the propagation, of the dissection. So this is why at the beginning we we used to use OCT when we had some doubts by the angiography, but OCT actually can act as a propagator for the dissection. So I think that wisely you should use an IVUS, which is showing in this case a normal external elastic lamina, not a typical pattern of plaque. Of course, OCT would present, an image that would be nicer, but this is enough to understand that this is not a typical aspect of atherosclerotic plaque.
Okay, thank you. So what about pathophysiology of spontaneous coronary dissection? We have to talk about two hypotheses, inside out or outside in. What's meaning? Inside out, this is an intimal tear with blood flowing from the true lumen. So the blood can enter the subintimal space from the true lumen after endothelial intimal disruption. The second hypothesis is outside in. This is an intramural hematoma that propagates and can cause the dissection, the occlusion of the vessel. So this is a picture that maybe explain the healing of the vessel or spontaneous healing of the vessel in spontaneous coronary artery dissection. So we can start with a normal vessel, intima, media, and adventitia. We have a mild intramural hematoma, then the extension of intramural hematoma can lead to occlusion of the vessel, or if we have intimal tear, we can have a decompression of the vessel and we can lead to healing. I don't know if this hypothesis can lead to healing of the vessel behind healing of the vessel after spontaneous coronary artery dissection. It may be logical physiology. You are okay?
Yeah, please go ahead.
So what about precipitating risk factors of spontaneous coronary artery dissection? We have the Valsalva or straining that increase the pressure in the coronary artery and lead to dissection, the intense exercise, the sex hormones, medications can also lead to spontaneous coronary artery dissection, emotional stress, pregnancy, especially in the postpartum, the first week postpartum, because of levels of hormones that can vary in the last week of gestation, connective tissue disorder such as Marfan syndrome, fibromuscular dysplasia and associated arteriopathy or hypertension. So what are the mimickers and differential diagnosis of spontaneous coronary artery dissection? The mimickers can be either coronary vasospasm, acute embolus or thrombus in the coronary artery aneurysm, or stair-step or cardiac pulsation artifact. What about differential diagnosis? One of the differential diagnoses is myocarditis that can lead to chest pain or the same pathophysiology of the same picture of ASCAD, Takotsubo cardiomyopathy, and Miroka. So here we have a cardiac cath images of the same patient before and after nitroglycerin injection. Anybody can comment?
Yeah, it's very nice. So I would like to have a comment by Vakas. Vakas, what do you think?
Yes, there is because two things come into mind. This is definitely, it looks like a spontaneous coronary artery dissection. But this may mimic with the coronary artery vasospasm, as very nicely explained in the picture, that after giving nitrates intracoronary, it went out. So
very, very clearly. Yeah,
yes,
that's
very
very,
clear.
very nice. And sometimes we forget to use nitrates, which are always available in the cath lab, but here the diagnosis is done and a stent is prevented.
Yeah, exactly.
Definitely.
So thank you. So the proximal RCA is showing a coronary vasospasm, severe spasm, but in the distal RCA or the PDA, we can show here in the rest images, likely it's a spontaneous coronary artery dissection just in the distal RCA. But the proximal RCA, it is coronary vasospasm. The second one, if anyone can comment.
Oh, wow. This is after POBA or just spontaneous?
Just a cardiac cath.
It looks like similar coronary artery dissection, and there is a filling artifact, filling defect, like a linear spiral clot formation in the coronary.
Yeah.
But still, in the second image, I am surprised at how it is healed. It is a later angiography, later after 2-3 weeks or something at the same time.
No, same patient, same day.
Okay.
Second injection.
So nice. in the second one, there is proximally something that maybe is it's not clear because we should see it in movement.
Yeah.
But it could be either a vasospasm or a dissection starting from the catheter and going through the entire vessel. That's another hypothesis.
Yes, maybe. Anyone
which is your interpretation of this? If any, Jagan, what do you think? Other ideas, Sylvia?
So at the first image, there is it looks like a dissection, linear dissection type 2 scat, for example, in the distal segment of the coronary artery. And it's not visible in the second injection. It's difficult to say. We have to see it in movement, so it would be easier to diagnose what's happened there. But it looks like a scat type 1 in the distal segment.
Yeah, but on top of this, which is true, Vakas also pointed out the possible thrombus in the mid part of the RCA in the first image, that white part that can be associated to spontaneous coronary dissection.
Yeah.
If you see more keenly in the mid course of the RCA, there is some positive vessel remodeling phenomena or something like mild disease in the mid. But this is it looks like a disease vessel, not so much normal vessel.
Okay. Thank you for your.
Let's see what Rima did in this case.
Okay. So this case, as shown, we see just a dissection like in the distal coronary artery in the figure A, although we cannot see it after the second injection. So this is an artifact because the second dissection, they do a good injection in the RCA and we cannot see it after. So this is an artifact.
But yeah, it could be an artifact, but how do you explain that white filling in the mid part and the what is it, the vasospasm approximately?
The second image or? No,
in the second one, the proximal part of the vessel, the proximal
part is not related to the film. We can film, though they took the image in the end of the film.
But I think we should see the moving images, otherwise it would be difficult to understand. Do you have it somewhere? No. Okay.
Just I have the images.
Yeah. Okay. So we will remain with the doubt.
Yeah. So this is the third case. If you can comment the last one.
Yeah, this is Vakas.
Yes, it looks like something like elongated heart, and there's a mid cavity obstruction. during the contraction of the LV cavity. And you see that all the coronaries are lie in the same longitudinal plane. Something like a thin lean image.
Yeah.
Thin young
It
patient.
seems a distal dissection of the LAD
Yeah.
leading to an apical wall myocardial infarction.
Exactly.
of
So
these
it's
images.
leading to Takotsubo-like cardiomyopathy. Exactly.
Yeah, but it's not a Takotsubo.
No.
Also because the real Takotsubo, you have during the systole an enlargement of the diseased vessel, the contrary of the disease part of the myocardium, usually the apex, but not always the apex. And
Yeah.
here it's smaller than in diastole, so it's probably just an apical infarction.
Yeah. Exactly.
It's-
Thank you. So just here. What about the management of acute spontaneous coronary artery dissection? This depends on the patient and the lesion. So if our patient is clinically stable with no high-risk anatomy on the vessels, so this is not a left main, not proximal vessels, it's not a big vessel with ATM3 flow, we go for conservative therapy and monitoring for 3 to 5 days in hospital. If our patient is clinically stable with left main or severe proximal double vessel dissection, we have to consider CABG in this case, or conservative treatment may be a reasonable option. The third one, if we have active ongoing ischemia or hemodynamic instability, we have to consider PCI if feasible, or urgent CABG based on the technical consideration and local expertise.
Yeah, I think Rima, these slides deserve some comments.
Mm-hmm.
I would like also to have the opinion of the other fellows.
Yes.
I don't know if you took it from some study or from some consensus paper or whatever. I don't think that doing a CABG is a good alternative for spontaneous coronary dissection, because
it would heal by itself and
yeah, okay. The first one, the last part of the slide is totally agreeable. If you have a dissection in a mid to distal part of the vessel with no symptoms, you have to leave it as it is.
Yeah.
Because doing a PCI in a spontaneous coronary dissection is associated with potential complications, more than a normal PCI. Mm-hmm. The second part, so a proximal vessel, left main, two-vessel dissection. I don't know if CABG is a good alternative, because angiographically, you just see an epiphenomenon and a part of the dissection. You can see just the restriction of the lumen. You don't see the extension of the disease. So there is also the possibility that you open the chest of a patient, you put a jump, and you attach it to a diseased vessel. That would be a mess. You would do a CABG which is unnecessary, leading to potential high complications. So if a patient comes to my cath lab with a proximal vessel dissection, I would try to fix it with a stent. Mm-hmm. Of course, with some tips and tricks that need to be taken into account in this type of PCI. But I would not send the patient to surgery.
Even if left main dissection or?
Yeah, mostly if it's left main dissection. Okay. On the other hand, for activating a CABG, it takes 2 to 3 hours usually, and left main with a dissection and the small lumen can be risky. Sorry, you can go ahead. Let me answer to the phone because I have another meeting in 20 minutes. Let me answer. Yeah.
Rima, may I ask a question, please?
Yes.
Yeah, at the bottom of the slide, when you said considering CAB or considerative risks may be reasonable, means that not study, means that is an expert opinion or based on anecdotal experience, what?
But most probably it's an expert opinion. I don't see studies that go for conservative treatment in the case of left main or severe proximal double vessel dissection.
Okay. Thank you.
You are welcome.
For this spontaneous coronary artery dissection and cabbage, I have a discussion with one of the cardiac colleague in surgeon in my
Yes.
hospital, and he's of the opinion that mostly for these dissections, especially coronary artery dissections, and if there's a left main involvement and patient is hemodynamically unstable, so and then they are trying to use the venous graft as instead of lima, because they are of the view that with the passage of time this dissection may heal up, and at times if we put the lima there, then lima will be lost and lima will not develop later on. So they are putting the venous graft in case of emergency surgery like this, especially with the spontaneous coronary artery dissections.
Yeah, okay, I understand, but technically, I have to confirm that the perspective of a cardiac surgeon is much better than mine from the technical and surgical point of view. But would you put a vein graft to a young patient, a 50-year-old male or female patient that for sure in 10 years will get occluded in this type of patients? That would make no sense, in my opinion. In my cath lab, if a patient comes with an involvement of the left main with a spontaneous dissection, this patient will undergo stenting for sure. Or maybe, if not stenting because it's too complex or whatever, cabbage, but with lima and rima. But no way of undergoing saphenous vein graft. It makes really no sense.
Yeah.
And I have a question, please.
Yeah.
If we go for PCI in the case of proximal dissection, and we cannot see the propagation of the dissection in the distal vessel, we have to stent all the dissection? The
problem with dissection is that, again, you see just the impairment of the lumen angiographically, but you don't see where is the extension of the vessel. So even if this is out of any guidelines, if it's feasible and if it's not risky for the patient, you should do imaging just to see the propagation of the dissection. And then you should land with a stent just distally, just at least 1 centimeter distally to that to the propagation of the dissection, in order to not to squeeze the hematoma and to propagate the dissection, which is still a risk. So this is why the key message is that you should not treat spontaneous coronary artery dissection unless they are leading to acute ischemia of the myocardium or they are involving the proximal part of the vessels. Okay, but if you have to stent, you have to try to understand where the hematoma is propagating to and try to fix it.
Yes, okay.
One thing more I want to know more about it. There are different school of thoughts. If there is an emergency situation and you are going to put the stent, should we start the stenting from the distal to proximal, or we should close the proximal entry point first, then go distal? What is your school of thought?
My idea, even if we don't have data about this, is to start distally and go proximally.
Okay.
Yeah. In order to reduce the risk of squeezing of the hematoma.
Okay. And as we know, the spontaneous coronary artery dissection, the presentation can be an ST elevation, and in every ST elevation, we give loading dose of aspirin and Predenta and heparin and whatever. That may increase the risk of intramural hematoma if we have spontaneous coronary artery dissection. Can we prevent this, or we cannot?
This is an important topic.
Yeah.
I had a discussion with Fernando Alfonso at CRT this year, because this year, earlier, or the end of last year, it came out a paper which was done by a Italo-Spanish collaboration, and the paper was published in the European Journal. It's called DISCO. So following this, it's a registry on CAD. following the information deriving from this registry, it seems that single antiplatelet therapy is better for SCAD patients. However, the experience of several operators, including Fernando, is that probably dual antiplatelet therapy is better. So this is why there is an ongoing trial addressing this issue. It's a Spanish trial, a randomized one, between single antiplatelet and dual antiplatelet. So a final answer is not there yet.
Yeah, okay. Thank you. So.
Okay, so I think we have finished the time. Yeah, okay, you have a few more slides.
This is the last DSC guidelines about the management of spontaneous coronary artery dissection. So the PCI is recommended only for patients with symptoms and signs of ongoing myocardial ischemia, a large area of myocardium in jeopardy, and reduced anterograde flow.
Yeah, this is a confirmation of what we said before.
Yeah. If you don't have time, we can.
Yes, I would like to see if there are comments also by the not physicians attendees today, if they want to have some more information or if they have some questions on this presentation.
Hello, I don't have any questions so far. Thank you for the pictures, the first pictures that you show. And I think they were kind of understandable even for us.
Yeah, thank you, Claudio. If you have another movie or pictures you want to show them, Rima, we have other 3 to 4 minutes.
Just another topic, a few slides, the catheter-induced coronary dissection.
Okay. If you compress them in 3 minutes or 4, it's okay.
Okay. So the second topic is the catheter-induced coronary artery dissection. So failing to prepare is preparing to fail. So this is the CCAD is an infrequent, infrequent but potentially catastrophic complication of coronary angiography and percutaneous coronary intervention, distinct and clinically different from SCAD, spontaneous coronary artery dissection. This is a mechanical disruption of the endothelial cell layer of a coronary artery followed by extravasation of blood into subendothelial tissue planes. The classification from type A to type F, the clinical incidence is less than 0.1%, most probably in the right coronary artery in the 50% of the cases, 45% of the left main artery, and more frequently during PCI because of the guiding catheter of the guide that can use during intervention. What are the additional risk factors for CCAD? Female sex is a risk factor, left main atherosclerosis, the use of amplatz-shaped catheters in the complex lesions, or deep seating of the catheter within the artery. What about prognosis? It depends on the size of the compromised vessels and the integrity of the anterograde flow. What about management? The rule is keep calm and don't inject, because if we inject more, we are in risk to propagate more the dissection. So this is an algorithm that can resume all the management if you have iatrogenic coronary artery dissection. So the rule is no further antegrade injection, institute appropriate hemodynamic support, use a passive guide catheter that avoids deep engagement, and attempt wiring of the true lumen with a nino-hydrophilic wire, plus IVUS examination. If the wire in the pulse lumen, we have to rewire under IVUS guided. And after, we have to do either conservative management or cabbage or bailout strategies such as retrograde approach, re-entry with the standing gray, or wire-based dissection re-entry. If our wire in the true lumen, we have to implant the stent, and we have to do complete coverage of the dissection or the hematoma. If we have residual dissection or hematoma and limited suitable for stenting, you go for stent for additional stenting. If it is unsuitable for additional stent with a TIMI-3 flow, we can observe. If it is unsuitable for additional stenting with a TIMI flow less than 3, we have to consider cutting balloon. So minor dissection may not require treatment. Those that are long or result in more than 50% stenosis with impaired thrombosis in myocardial infarction flow, or the vessel is more than 2.5 millimeter, considered severe and should be treated.
Yeah, usually, correct. Very nice, very nice. Also, this part. Usually, the proximal dissections that are created by the catheter should be fixed with a stent. Yeah. That's quite clear. In my practice, the most common catheter causing a dissection in the left main is, for a diagnostic catheter, a Judkins left. And for the guiding catheter, as you said, the Amplats.
Okay.
But overall, for the right, LA1 is the most supportive guiding catheter. For example, if you do a CTO of the RCA, you should use an Amplats, but you should be also skilled to manipulate the Amplats 1 or 1.5 or 2, because those are really associated to a high risk, an intermediate risk of proximal dissection, iatrogenic dissection, if you are not experienced.
Okay.
And another setting of the dissection is the angioplasty of RIMA, which is not you as a physician, but RIMA or LIMA. Yeah. Because I have had a couple of dissection in this setting, because the guiding catheter is quite aggressive when you manipulate and you try to get the ostium of the mammary artery. And you usually treat the anastomosis or the original vessel, the LAD, without giving a look at the RIMA or the LIMA engaging the artery. You always forget about it. Mm-hmm. And so when you do the final shock, you should analyze and assess very clearly if you have created a dissection there. This is, I think, a useful tool that you should, but if you don't send patients to the cardiac surgeon, you don't have this issue. No problem.
Okay.
That said, I think you covered very nicely the topic, Rima. I would like to thank you. I don't know if there are other questions by the audience. No, Vakas also agrees that it was a nice presentation. Rima, I would like to see your face 1 second.
Yes.
Sure. If it's possible.
Yes, sure. 1 minute.
Yeah, you should exit the...
Yeah.
Yeah, let me do this. Yeah. Okay, because yes, I would like to put this in our media. And it's very nice. So I don't know if you had, guys, the chance of voting at the poll yesterday for the time for the next presentations. I don't know, Lisa. I don't know if Lisa is still available.
Yes, I'm here.
Who was the winner in terms of time?
At 5 maybe p.m. set.
5 p.m. Okay.
Yes.
So Rima, is it okay for you? 5 p.m. I don't know which time did you vote for.
I will do my best, but I prefer more in the night.
In the night?
We have colleagues that are very far.
Yeah. The colleagues in India and Pakistan.
5 is okay.
Yeah, it would be an issue for them. So maybe 5 is better than 3. Huh?
Thank you so much.
That's fine. Okay, no problem. So thank you. It was a pleasure having you here, and see you next time. Lisa, can you remind us the next presentation at the time?
Yes, it's next Tuesday for the update of DCB Academy at 3 p.m. I confirm.
Okay, this is for the updated scientific paper, but for the lesson?
Always 3 p.m. Always 3 p.m.
Yes, but when? The 21st?
21st, yes.
Okay, 21st. Okay, great. So thank you.
Thank you so
have
much.
a nice evening.